Good morning, good afternoon, good evening, dear colleagues, dear friends. It is my great pleasure to welcome you to the webinar conducted jointly with WHO and WHO Collaborating Center in Ukraine, National Research Center for Radiation Medicine. It is my great honor to welcome excellent speakers and experts on Chernobyl-related matters who joining us from the US, from Ukraine, from Austria, and from the Netherlands. My name is Carr. I am the technical officer at the WHO headquarters at the Radiation and Health Program of the Department of Environment, Climate Change, and Public Health. Today, as you know, is a very special date. We are commemorating 35th anniversary of the worst nuclear accidents in the humankind history. It affected very large areas of Europe and mostly, of course, Belarus, Ukraine, and 4 areas of Russian Federation. More than 10 million people were affected in one way or another. And also some people, of course, lost lives fighting the Chernobyl fires in the very early days and weeks after the accident. To open the webinar, I will pass the floor to the head of the WHO office in Kiev in Ukraine. Jarno, please, the floor is yours. Thank you.
Thank you, and good morning, good day, good evening, wherever you are. And I know that we have a number of you following us today as well. Maybe some of you are looking to the recording after. But it is an important day where we commemorate the 35 years from the catastrophe what we had in Chernobyl. But we will hear from colleagues who are talking more what has been since, what are the lessons learned, but also what has been there, what we can learn from the past, also thinking as we are going through the COVID outbreak now across the world. And there are many lessons that we could maybe learn and how to put together. Together with us, we have, of course, our collaborating center and with whom we are closely working, colleagues across the world, but also some colleagues from another UN agencies, because while the current event is hosted by WHO together with our collaborating center, we have a number of UN agencies from UNDP, UNICEF, others who have been working to support different population groups, looking to research, looking how to support. And the support has been varying over these 35 years. So there is a lot to learn and to reflect as we go through today's webinar, but also Shanata has been leading this work and also from WHO's side, and there have been annual meetings and annual reflections. So while today we look last 35 years, there have been many of similar reflections during the years. I'm thinking myself how I relate to Chernobyl, and I must say, I was thinking when and where I learned about that. But and it's very personal because I must say I have a birthday around the same date as Chernobyl. And I was supposed to have my 10th year birthday. But after we heard what happened, I had to cancel it and stay inside. So even when I was back at home in Estonia, 10-year-old, thinking about my birthday, when I heard about the accident, that changed also my own life, at least for that year, but it has affected millions across the world also, and that point of time and after. So each of us, we have our own story and reflections, and that's also important that we bring this one in. From WHO side, we have been supporting and the work in this field with the different forums, the dialogues, and looking to the health effects. There has been a lot of research that has happened among those who have been serving there and the follow-up, but then also the population groups around. In the past years, we have been looking on the radiation safety. So I want to say that over those 35 years, this has initiated a lot of research, the dialogue, and lessons that we need to learn. And the latest what we have been doing in Kiev and here in particular is in 2017 to 19 to really support the healthcare workers who are supporting their Chernobyl employees on particularly looking to the non-communicable diseases and chronic diseases. So let's use this opportunity to reflect, to learn, but then also think how and what lessons we can take with us as we go through the COVID outbreak. So thank you, and back to you, Shanna.
Thank you very much. Thank you so much for your very wise opening. I also would like to share my own story, what happened and what Chernobyl means for me. In fact, I was a medical school student in 1986 at the third year of medical school, and I had a 3-month-old baby who I was breastfeeding. And when it happened in April, I actually was also diagnosed, although I come from Kazakhstan, which is very far from Ukraine. Of course, I was by no way affected by the radioactive iodine, but Kazakhstan is the endemic area for thyroid goiter. And I was diagnosed as a breastfeeding mom with thyroid goiter. And I was sent to do a diagnostics and somehow I received the radioactive iodine dose as a process of diagnostics for my thyroid. So this is very bizarre coincidence. But I initially, when I started working for the WHO in summer 2002, that was at the very start of the Chernobyl Forum project. And that was the reason why I was actually hired, because the radiation program at the time was looking for English-speaking, Western-trained, Russian-speaking, Western-trained scientists. And my profile somehow fit the requirement. And my first assignment at the WHO was working on the benchmark report, summarizing 20 years of research of health impact of Chernobyl accident. And during these years, it was a tremendous learning experience for me and a great honor to work with our collaborators in all 3 affected countries, in Ukraine, in Belarus, in Russian Federation. And I'm really happy to introduce our next speaker, the director of the National Radiation Research Center for Radiation Medicine, Professor Dmitry Bazika. Dmitry, the floor is yours.
Thank you, Janet. First of all, I want to thank on behalf of our center to you and to Dr. Habich for many years of joint work in the problems of Chernobyl. I want also to say that our center is a WHO collaborating center in REMPAN and environmental health, makes everything to promote these activities. Now I will try to open and share my presentation. Is it okay?
Yes, we see it.
Okay. So my presentation is about the Chernobyl lessons for preparedness to radiation emergencies. First of all, the early period, the early decisions that were of key importance to the protection of public. First of all, stable iodine prophylaxis, sheltering and waiting for further instructions, evacuation, later decisions, population resettlement from shelters, and access to previously excluded territories. So, first of all, I will speak about the iodine prophylaxis. Its efficiency decreases dramatically after exposure and reaches only 7% in 24 hours after irradiation. The Soviet official information reports, according to them, a start of stable iodine prophylaxis in Pripyat was on morning of April 26, 1986, 10 hours after the accident. No registry of persons receiving the stable iodine was created. Some information was included to the Chernobyl State Registry based on the later interview. I can say that even the numbers of people receiving the iodine prophylaxis are not controversial. For the USSR Ministry of Healthcare, they reported about the 5 million of population. Ukrainian ministry reported the same figure for only Ukraine, including more than 1.5 million of children. Large-scale iodine prophylaxis was performed later for cleanup workers after the end of iodine period. Analysis of questionnaires filed by the subjects by our leukemia project study demonstrate no connection of self-administration with the late effects. Sheltering. In Pripyat, sheltering information was distributed with delay. For Kiev and other territories, the sheltering information was introduced on May 10 after the radioiodine release and territory contamination. Estimation of efficiency of sheltering is not possible. Evacuation. Preliminary decision of evacuation was adopted on the second part of the April 26th day, and dose rate in some areas of Pripyat town received several millisieverts per hour. After that, till 9 p.m. on April 26th, a total of 1,350 Kiev city buses, 2 trains, 3 ships were moved to Chernobyl, and then at 10 p.m. a decision of instant evacuation was adopted by the Ministry of Healthcare. Placement of city buses during several hours in the proximity of the reactor resulted in substantial radioactive contamination and subsequently radioactivity transferred to Kiev after return of buses to garages. Evacuation was performed on April 27 between 2 and 5 p.m. Pripyat population almost 100,000 and Yana, including 7,000 children and 80 hospitalized disabled patients. I want to say the difference with Fukushima was that none of the deaths was shown for the hospitalized patients. Decisions of evacuations of inhabitants of the 30-kilometer zone. Decisions were adopted using the field measurements. Subsequently, evacuation started on May 2nd and was finished on May 7th. Decision of evacuation was adopted for population of territories with ether plata of 0.5 millisievert per hour that correspond to the dose of 100 millisievert and more. Those limits for evacuation were introduced by the Ministry of Healthcare of USSR. For Kiev and adjacent areas, 700,000 of children were relocated from the accident area for 4 months for summer, starting from May 15. Such approach enabled decrease of radiation dose to 30% as minimum. There was a lot of mistakes. For example, choice of some places for relocation wasn't optimal. In some cases, after relocation to clean territory, radiation dose was increased due to the additional irradiation from natural sources like radon. Daily washing and other countermeasures in total for 1986-89 period, the efficiency was around 10%. Countermeasures to avert the internal exposure. More than 50% of internal exposure was due to ingestion of milk contaminated by radioactivity. Replacement of local milk and other foodstuff was done, and it was substantially decreasing the internal radiation dose. So the countermeasures led to an 11-fold dose decrease. Later decision, relocation during 1989-93. It was done for more than 200,000 of inhabitants, and very conservative criteria have been used. These actions were based rather on social than a scientifically based background. Conservative approach directed to decrease the community tension led to risk of estimation by population and doesn't prevent mistrust to governmental decisions. About the effects registration. State Chernobyl Registry of Radiation Exposed was introduced. It covers all the territory of Ukraine and contains 2.5 million of exposed, including 305,000 cleanup workers. Annual health information was collected during 1988 to the year 2011. National Cancer Registry was introduced since 1996 with the help of Columbia University, Dr. Howe. It covers all the territory of Ukraine and used for linkage with the Chernobyl registry. And of course, there are local registries of exposed professionals on nuclear power plants, in nuclear industry, and in the Research Center for Radiation Medicine. They are used for validation of the state register. After Chernobyl, very strict legislation on radiation protection was introduced. Here you see the comparison of Ukraine legislation of 1997 with the ICRP publication 63. With the red figures, you see the parameters that have not been regulated by ICRP, like sheltering for children, thyroid dose, skin dose, iodine prophylaxis for adults, different than for children, thyroid dose, evaluation, and skin dose, milligray. And these are the laws that have been adopted after Chernobyl accident. I can say now that Ukrainian government and authorities are trying to introduce new legislation that will be harmonized with the European community and the Euratom directives. Late period after the accident. Here you see new arch in the year 2011. The 99% of radiation dose calculated for a 70-year period are received. A decrease of radioactivity transfer from 30-kilometer zone and from shelter covered from New York decreases doses in staff. Negative demographic tendencies in all group of exposed are registered. Increased incidence rate was shown for cancers and non-cancer effects. And there is a need of constant need of to-date health care for exposed. So the registration of those was performed by dosimetry spotization in more than 2,000 of settlements. Last one in the year 2014. Now, a need in EU passportization is to determine the possibility of industrial and economical use of the formerly contaminated territories. Increased risk of internal exposure was registered last year, in 30-kilometer zone when a lot of wildfires were registered in Chernobyl forests. Our center has performed a lot of work in this area, and you can see here firemen who were under the dosimetry of internal exposure. And now the effects, the late effects. First responded the high dose late exposure effect, For cleanup workers, cancer after low dose, leukemia, multiple myeloma, thyroid cancer, breast cancer, other solid cancers. And as of non-cancer diseases, cardio-cerebrovascular, cognitive deficit, radiation, cataracts. These effects need further studies, and our center is working to promote such studies. We have now the need of network. This network includes Ministry of Health cards here, radiological laboratory, dispensaries, medical sanitary units, state agency of exclusion zone, Ministry of Energy, National Academy of Medical Science. I can say that now our healthcare system is in a reform, so there is a need in working system for radiation exposed, as there is a possibility that the health radiation exposed would be stopped or done not so thoroughly. Here, there is a lot of national reports. The last one, national reports on Chernobyl, was issued today. The Ukrainian version and the English version will be introduced in 1 month. So, summary. Decision-making system works well in the case of small and medium-scale accidents. After the severe accidents, like Chernobyl and Fukushima, there is some delay between the exposure and the decision to implement countermeasures. Delay in radiation protection should be shortened by deleting some anchors. Distribution of kali iodine. Families at the communities near nuclear industry installation have to be supplied with a stock of kali iod preparation. Sheltering has to be used as early as possible. Special understandable print guidelines have to be distributed among population. Lack of such recommendation had a substantial negative effect after Chernobyl. Recommendations adopted after the accident often have been politically motivated and based on emotional factors or pressure from population due to a loss of trust rather than on principle of radiation protection. Local hospitals and medical staff for a certain period need to have resources to provide healthcare without external support. And non-radiation effects and effects due to combined influence of radiation and other factors prevail upon the effects due to only radiation. Discrimination between the health effects is competence of science and is not important for the healthcare system. Thank you for your attention.
Thank you very much, Professor Bazika. It's true that prior to the Chernobyl accident in 1986, in fact, the international standards and norms and guidance were not really available at the international level, at the global level, for managing and responding in the form and state as they are available now. And as Chinese proverb says that every crisis is a possibility for improvement, this was exactly the case. After Chernobyl accident, they were put in place 2 international conventions for notification and for assistance in case of nuclear accidents, and a very firm and functional international arrangements for coordinated support and response, also applying for preparedness stage. They are now in place and led by the International Atomic Energy Agency for the UN family. We also appreciate the enormous work done by national research institutions and healthcare facilities. It was indeed enormous burden on the national public health systems. And the first 15 years after Chernobyl, the UN system considered it as an area of humanitarian disaster, and the coordination for UN actions was led by UN OCHA, Office for Coordination of Humanitarian Affairs. Since 2001, the coordination was passed to the United Nations Development Programme, UNDP. And for the last 20 years, UNDP has been working quite actively in the field. And WHO had really a pleasure and honor to participate in the joint project with UNDP back in 2007 through 2012, 2013. It was ICRIN project, International Chernobyl Research and Information Network, within which we worked each in our specific sector. WHO targeted healthcare sector, UNDP targeted support to the small businesses and reconstruction of the areas, bringing them back to the providing business opportunities and improving the social determinants, which are very important in ensuring access to healthcare, to improving the well-being of people. So UNDP has been playing a crucial role in this type of area, in improving socio-economic situation in the affected areas. So with this, I would like to pass the floor to Mustafa Said Ametov, who is representing UNDP today. And Mustafa is a regional development program manager since 2020, and he specializes in sustainable regional and local development. He previously served as a regional SDGs portfolio manager and program coordinator and project manager for infrastructure rehabilitation and economic recovery component of the UN Recovery and Peacebuilding Program in the Eastern Ukraine. And he holds a PhD degree in mathematics. Mustafa, the floor is yours for the next 15 minutes.
Thank you so much, Janat. First of all, I would like to thank all WHO colleagues for organizing this very important event and inviting us. And also on behalf of UNDP, I'm honored to welcome all the participants to this event. My particular gratitude goes to Professor Bazika for his excellent presentation, and actually looking at those old photos, one can literally feel the horror. And thank you for reminding all of us how it was and what the terrible impact the Chernobyl disaster put on people, and many thousands of people's lives were literally destroyed by the disaster, and actually it negatively impacted the lives of millions. So I know one of the key lessons we learned from that these kind of disaster, they do not limit just to impact on people's health. Actually, they generate a multi-factor crisis, which have to be considered and addressed from different perspectives. So, dear participants, after 35 years since the Chernobyl disaster, the sustainable transformation and recovery of the affected areas remain a long-term challenge for Ukraine as well for other affected countries. It is a huge undertaking which will only be accomplished with collective actions by all partners at all levels. And UNDP has been contributing to the local development and recovery and development of Chernobyl affected areas since 2004, when it was, as Janat has already mentioned, designated as a key agency for coordination of all UN activities in Chernobyl. Today, even though UNDP does not have a standalone project, I mean UNDP Ukraine does not have a standalone project dealing with Chernobyl catastrophe, it continues providing targeted support within our ongoing projects. I will demonstrate a few of them very soon. But before that, I would like to mention that UNDP advocates for return to normal, economically active and healthy life of people living across the Chernobyl affected areas and regions through mitigation of long-term socio-economic and environmental consequences of the Chernobyl catastrophe. Even though Chernobyl affected areas are mainly rural and have limited opportunities compared to others, UNDP interventions have stimulated communities and local authorities to become more active and successful, addressing the priority needs of local population. One of the major UNDP goals in the region is to provide the local authorities these methodological and financial instruments to eliminate the Chernobyl stigma, to generate resilience and economic opportunities at the local community level, and return citizens to life without limitations. However, there is still a range of issues, and they call for a new targeted interventions. They include quite serious natural disaster insecurity across Chernobyl affected region. In particular, as Mr. Bazika has already mentioned, the forests and peatlands contribute to constitute one of the main economic and livelihood opportunities, and the disruption in their existence is a real threat for the well-being of the communities. Forests and peatlands fires promoted by the climate change occur more frequently in Chernobyl affected areas and in the exclusion zone, and that represents a serious health hazard. As Professor Bazika has already mentioned, in March and April 2020, forest fires spread in the Chernobyl exclusion zone and Zhytomyr Oblast, causing unprecedented level of air pollution, even in Kiev, which on April 17th of 2020 has become one of the cities with worst air pollution in the world. To address this problem, UNDP has supported the state emergency services of Ukraine with reducing the impact of natural disasters in the Chernobyl exclusion zone by improving the assessment of wildfires. In spring last year, the firefighting crews in the Chernobyl exclusion zone and Zhytomyr Oblast were employing a drone to track the wildfires in the early stage and prevent the exclusion of the fire on the larger territory. The drone with a built-in thermal imager has been purchased by the United Nations Development Program under United Nations Recovery and Peace Building Program. In November, the state emergency service in Donetsk, which the mentioned program is one of the programs implemented by UNDP in Ukraine with support of EU. We also, as a part of United Nations Development Program in Ukraine, we have an acceleration lab, which is all about innovations, and it's working in a number of communities, including those affected by Chernobyl. And they have recently launched a project called Do Not Burn, Compost. This initiative so far have covered more than 200 communities, which are currently mobilized and act on preventing of open burning and fires. Using collective intelligence, logic, communities are exchanging knowledge and practices regarding alternatives to open burning, such as, for example, composting, sustainable agriculture, bioenergy, and so on. So the Acceleration Lab is now looking for other opportunities, including those generated by new technologies, for example, collecting data from satellites to prevent wildfires. Actually, this is just one example. I have some more to share with you of how UNDP Ukraine is currently addressing the multidimensional consequences of Chernobyl catastrophe in the area. So let me share my screen maybe at this point and present a few initiatives which are currently implemented by UNDP Ukraine. So let me start with a project which is called Homeowners of Ukraine for Sustainable Energy Solutions. The UNDP in Ukraine continues its work on community mobilization and supporting the most vulnerable groups of population across Ukraine, including those in Chernobyl affected regions, through the framework of this large-scale initiative, also funded by European Union. The project contributes to the improvement of energy security in all 24 oblasts, including the territories affected by the Chernobyl disaster. UNDP directed its activities within this project on reduction of energy consumption and reduction of CO emissions through the improvement of good quality of housing. Most importantly, within these initiatives, that people in the communities are really engaged. So through responsible ownership and participation, they become a part of a broader movement for changes at local level. UNDP in Ukraine also implements a JEF-funded small grants program, which has incorporated the support provided to Chernobyl affected communities into a regular development program on the Polisia landscape of Ukraine. And the small grants program promotes inclusive and efficient environmental management through a number of small-scale projects. Just to mention that recently an information center called Chernobyl, the Territory of Change, opened by with UNDP support, is now fully operational and aims at raising public awareness of results of regular environmental monitoring on radiation in the exclusion zone and beyond it. Also, the current conditions for ecosystems in Kiev and Zhytomyr, Polisia, measures aimed at preventing possible impact of the exclusion zone objects and radioactive exposure on the population. It also increases the awareness of prospects and possible ways for sustainable development in the exclusion zone and the territories around these areas. And the actually some of the scientific researches which are conducted in the exclusion zone are also exposed due to this information sharing center. Another example of a small scale initiative that's very important is this eco-education center called Ecology Space, opened in, and actually it was established quite recently in 2021 with support of JEF Small Grants Program. And it aims in the following areas. It's accumulation of information about ecological measures and innovations of Ivankiv and Polisia districts. Both belong to Kiev Oblast. A center for providing information to the current environmental situation. And also it serves as a place for implementation of environmental research and creative initiatives for carrying out ecological and educational initiatives in the area. The next one is called Removing Barriers for Increased Investments in Energy Efficiency in the Public Buildings through ESCO modality and in small and medium-sized cities. This initiative was launched by UNDP following the MOU, which was signed back in 2019. Actually, it was a pilot for increasing energy efficiency in Slavutic town. And this is the first Chernobyl affected community that has tested the new and innovative enhanced ESCO modality to improve energy efficiency in public buildings, where the co-investments from municipality has been envisaged and fully fulfilled. So far, 2 public buildings were thermally modernized and insulated using the results of energy audit conducted by the project. Furthermore, the energy efficient ventilation is planned to be installed. Then all planned activities will be finished. The energy cost will expected to drop by 35% at least. Lastly, maybe I will mention another initiative which is not related with investments into physical infrastructure, but rather into social capital, which is the initiative called Civil Society for Enhanced Democracy and Human Rights. Focuses its activities mainly on decentralization and anti-corruption reforms in Chernobyl affected areas. Special attention is paid within this project to further strengthening the civil society and its capacity to engage in local planning, decision-making processes, the human rights protection, and the promotion. Specifically for so-called CSO hubs were established in Rivne, Zhytomyr, Chernihiv, and Kiev Oblast, and advocacy activities of CSO hubs focus on analyzing subnational policies through human rights-based approach. An inclusion of vulnerable groups in decision-making processes and establishing access to free legal aid for people from vulnerable groups. The development efforts in Ukraine are now linked to attaining the 2030 Sustainable Development Goals to be incorporated into governmental programs and strategies. These shall allow creating innovative partnerships, mechanisms to promote investments in Chernobyl affected areas to ensure that no one is left behind and people's aspiration for prosperity and healthy life without Chernobyl limitations are fulfilled. So let me finish my, my speech maybe with emphasizing that another important lesson learned from our work in Chernobyl affected areas and many projects and initiatives implemented to overcome its negative impact is that this work is only possible in partnership at all levels, and the most successful initiatives are usually planned and implemented in close partnership of national and local governments with international organizations, but also involving the civil society, the people from the areas, and including them at all stages from designing the actions to implementing, and also at the stage of monitoring which ensure the sustainability of such actions. So, dear colleagues and partners, this is just few highlights maybe from our work and efforts aimed at sustainable recovery of Chernobyl affected territories. And I'm absolutely sure that hand in hand with other partners, with other UN agencies, but also with all national and international partners, it's achievable to restore, to recover the areas and people's livelihoods. And but one important lesson we should learn and never let this happen again. Thank you so much for attention, and over to Janat.
Thank you very much, Mustafa. Extremely important aspect of the recovery efforts and of all the developments which are happening in Ukraine, including the affected areas by the Chernobyl accident. And actually, prior to Chernobyl accident, I think the culture of involving stakeholders, involving actually people and NGOs and active groups in the decision making was probably not really well developed and not well structured, not well instrumentalized, let's say. But after Chernobyl, this has been more and more developing, and especially after Fukushima accident, we've seen a very big breakthrough, let's say, in this area. And it is something which we are also, as a WHO, are really working on, trying to see how we can improve the system of the preparedness and planning for response to radiological nuclear accidents by bringing in the social aspect and dimension in the arrangements, in the requirements, and in the criteria for applying the protective actions. Also, one of the most, let's say, well documented and the largest impact of the Chernobyl accident on the human health and public health is been reported to be the mental health impact. And we know that mental health today, especially today in the age of pandemic, we see that it is very much linked to the people being isolated, people not being socially engaged, and there is also issues of social stigma, people are suffering. So the next presentation will really focus on the importance of mental health impact of this type of accidents. And it is my honor to present Professor Evelyn Bromet, who is a distinguished professor in the Department of Psychiatry and Behavioral Science at the Stony Brook State University of New York, USA. Her research on disaster mental health started with a groundbreaking study of the psychological impact of the 3 Mile Island nuclear power plant accident on mothers of young children and the workers of the plant. Later on, after the Chernobyl accident, she collaborated also with the Ukrainian Psychiatric Association on the first psychiatric epidemiological research of the psychological impact of the Chernobyl accident. Evelyn worked also in close collaboration with Professor Johan Havenaar, who is her co-presenter and co-speaker. Johan is from the Netherlands. He used to be with the Utrecht Institute of Space Research. I'm not sure he will tell us what is his current affiliation. Johan is the author of dozens of publications and has done some massive research on the subject of mental health impact of nuclear accidents. And he also is the author of the book Toxic Turmoil, which is available on Amazon for those of you who are familiar with this book. So both of them are presenting the next talk on the program. So I think the floor first is with Evelyn, right?
Yes.
Go ahead.
Yes, thank you. It's very interesting to be here. And also, I have to say, makes me feel very sad to sort of go back through all the turmoil and the frightening events that happened around the time of Chernobyl. I just want to begin by saying that My very first trip to Kiev was in 1990 when WHO organized a 1 week long meeting on the mental health effects of the Chernobyl accident. And it was fascinating actually, because it became completely obvious that the parallels with 3 Mile Island were just very clear and surprising, because 3 Mile Island, as you know, was not a complete meltdown in the same sense. But so let me see if I can do as good a job sharing my screen as everybody else has. I did.
Yes, you did. Now you just need,
Wow.
yes, exactly, slideshow, perfect.
Oh, excellent. Well, I have to say, I am very happy. Last time I tried to do this, I don't know what happened. Okay, so let me begin by saying that studying the mental health impact of Chernobyl and now of Fukushima and even of COVID is part of a long history of studies, research, and treatment on disasters in general. And what's been really interesting is to look at the extraordinary explosion of studies that has gone on since World War II, really. I will say that there have been very few studies of the atomic bomb survivors. There are a few now, long-term studies looking at, you know, people 30, 40 years later. But at the time that the research was set up, the focus was only on cancer and other medical problems, and absolutely not on the psychological or psychosocial impacts of what happens, the extraordinary, awful things that happen. So as you can see, the number of research papers on the mental health effects of disasters has just exploded, especially since 2000. There are methodological reasons for that in terms of the development of measures for doing community mental health research. But there have also been a lot more horrible disasters that have gone on that have really fueled this. I cut off my search at 2019 because once COVID started, the literature is now glutted with studies, some good, some absolutely misleading in terms of the mental health impact, in my opinion. We'll talk about that a little later. When people are talking about mental health effects of a disaster or of Chernobyl, the kinds of symptoms that they're talking about or disorders that they're talking about range from post-traumatic stress disorder, which is the most commonly studied outcome, to depression, grief when there are a lot of deaths, panic disorder, somatic symptoms, especially headaches, severe headaches, substance abuse, suicide ideation, and insomnia. And the proportion of people who report these kinds of serious problems range a lot in different studies, depending on who's in the study, when the study took place, how horrible the event was, how involved the people in the study were in the event, and so on. So it's very hard. Every disaster is a unique experience, and it's very hard to put all of these amazing, horrible stories together and say, so this is the rate of, I think that's impossible. So at least 20% in the first couple of years of people experience these kinds of symptoms. And for many, it reaches the level of an actual diagnosis. The factors that are associated with developing these kinds of symptoms have to do with the severity of the disaster and the involvement that people have in it, whether they are cleanup workers or people who were evacuated versus people who were affected in a less severe way. And also the basic vulnerability factors that you would find associated with mental health in any study that you do of mental health. So they are variables like people's psychiatric histories before you see them, demographic characteristics, lack of social support in their lives, other stressors that have gone on, and so on. So what's different about a toxic disaster or a radiation disaster is that the effects on mental health are driven very largely by people's fears about their health, their negative risk perceptions. So why did that happen to people? And it happens very quickly after these events. It happened very quickly after 3 Mile Island, after Chernobyl, and after Fukushima, that people began to worry that their health was affected, their family's health was affected, their potential grandchildren 20 years from now were going to be disabled in some way. So one of the main contributors to this, I have to say, is us, is scientists and medical doctors who, along with government experts and people who run these industries, gave contradictory information after these events happened that were really frightening for people because they didn't know who to believe. And if you don't know who to believe, then you usually believe the worst. And after Chernobyl, it was even worse because the local doctors did not know what the effects of radiation were. And they interpreted all the mental health complaints that people came with as being affected by Chernobyl. So if you went to a doctor because you were worried, you were having stomach pain and your heart was beating and your head was exploding, you were given a diagnosis called vascular dystony in many cases. This is early on. That indicated that you've been affected by Chernobyl and that this was a radiation kind of long-term effect. The other problem with these risk perceptions is not only were they reinforced by scientists who disagreed with each other and local doctors who didn't know what they were doing, but they also became intractable over time. So meaning that once these perceptions set in, it's very hard to convince people that it's not true, that maybe they weren't even exposed to the level of radiation that they think they were exposed to, and that the likelihood that they're going to develop these kinds of health problems and die early and may not be the case. It's just impossible. And partly it's impossible because the distrust in authorities that happen after these events are very deep and almost very difficult to change people's minds, because these authorities are often famous scientists in various countries, people in positions of authority that you should feel like you should trust. So there's a whole background to why mental health was affected by Chernobyl and why it went on for the negative effects have gone on for such a long time. The groups that have shown up as being of particular risk after Chernobyl and also after 3 Mile Island and also after Fukushima are mothers with young children and pregnant women who were really terrified that their children were going to end up with terrible medical problems. And the cleanup workers who were also, very involved in the work that they were doing, very exposed to radiation compared to other people. And many of them were also at the time, because of the stress of the work they were doing, consuming a lot of alcohol and and smoking a lot and not really taking care of their health to begin with. So after 3 Mile Island, after Chernobyl and after Fukushima, there were international reports that were written, and this is really the theme of our talk, and I think Jeanette sort of mentioned it. And these reports basically said that the most important public health threat after these events is not physical health, although obviously there are examples of thyroid cancer and other cancers that have happened, but the biggest public health threat was on mental distress. And research that was done found very strong associations between people who perceived that they were exposed, whether or not they were actually exposed was not relevant, and began to worry about their health. And as a result, developed a lot of mental ill health problems that I showed you. All of that means that if you're really going to do a serious study of the health effects, mental health effects of a radiation disaster, it's incumbent on you to do a serious study, not just of mental health, but of physical health at the same time. The language for this now in medical settings, at least in the United States, is called integrated medicine. So there's been a real push here for physicians to be on the lookout for mental health problems, for psychiatrists to be on the lookout for medical problems, and to treat both medical and physical health equally seriously. But if you look at the research that's been done after toxic events, it's either been on mental health or it's been on physical health. And there are very few examples of studies. Johan Havenaar's study in Bromet is a perfect example. It was a two-stage study of a population base that was done 6 years after Chernobyl happened in Bromet with a comparison sample in Tver, Russia, where he looked at people's self-reports on standard self-report instruments about their mental and physical health. And then he had them examined by a psychiatrist and by a medical doctor to make ratings of their health. And the two sources of information didn't match. They didn't match in our study either, where we studied children in Kiev and their classmates as comparison groups, and later as a population control group. We asked the mothers about the kids' health. We asked the kids about their health and their mental health and their cognitive performance. And we did neuropsychological testing and all of that. But when we brought the kids to a clinic where they were examined using a protocol that was developed in the United States, we trained physicians over in Kiev to do these exams with the kids. They were basically fine in spite of their self-reports about all sorts of health problems. So there were a lot of lessons that were learned over the course of the 35 years since Chernobyl. One of them, I think Johan and I implemented, but most other people did not, which was to look at both physical and mental health at the same time, so that you understood the dynamic between the two, you understood what was real, and you understood all the ramifications of the mental health effects and where they came from and how they evolved over time. So doing this work longitudinally is also very important. Another thing that's really important, and I think this has been totally lost in the COVID studies, is enrolling and maintaining representative samples of people from whom you can generalize, whether they're people in treatment or people in the general population. So it's not enough to put out a questionnaire on the internet and offer people $5 to fill it out and think you've now learned something about the prevalence of mental health in relation to COVID, which is what a lot of these studies have been. I'm an editor for a journal that receives a lot of these papers. So I'm very concerned about the quality of the work that's being done about COVID, because I think for COVID patients, there are long-term effects that include depression and chronic fatigue and things that are covered by mental health rubrics. But these regular surveys that are going on, I think, are giving a false picture. And a lot of that has happened, I'm afraid, also in Fukushima, where they have mailed out questionnaires to people and gotten very few of them back. So the response rates have been low, and the likelihood is the people who have responded to these surveys are people who are worried, people concerned about their health. And so you're getting inflated views of how these events have affected people. It's also important to use these monitoring surveys as ways to communicate with people about their risk perceptions. And I think in Japan, they've done a fantastic job of doing that. They've taken this whole concept very seriously. So instead of just doing studies of, PTSD and people's risk perceptions, they've actually sat down with them afterwards to talk about their risk perceptions, to talk about where they were, the likelihood of their actually having been exposed to radiation, and so on. And it's really critical because as monitoring surveys are done, it means you're monitoring people over a long period of time, and you're almost creating a situation where people think, if I'm in a monitoring survey, then there must be something wrong with me. So I think the activities going on in Fukushima are really fantastic. When we finished our study in Kiev of children, in our consent form, we told people that or published anything in the media or in the scientific literature, we were going to meet with them and tell them what we found and discuss it with them. And so we had a community forum in downtown Kiev with our study participants. They brought their neighbors, they brought their friends, where we described what we found, and then we opened it up for questions. And it was actually one of the most emotional experiences I've had in relation to doing this kind of work. And I learned a lot from the people whom we were studying about what their concerns were, which went far beyond their worries about their kids in relation to radiation. I just want to mention one other thing before turning this over to Johan to talk about what do we do about this. And that is that when Chernobyl was studied, people were either doing monitoring studies for different cancer outcomes, or like me, they were doing studies that were really focused on mental health and how that evolved over time. After the World Trade Center exploded, and this year is the 20th anniversary of the World Trade Center bombings, explosions. The Center for Disease Control, the CDC, created a series of health monitoring programs mostly for responders, although there is one program that also includes people living in the neighborhood nearby. And these programs give people the opportunity to be monitored every single year if they want to. Most of them, the average time is 1.5 years to 2 years. So this has been going on now for 20 years. The monitoring includes both physical health and mental health. So we have detailed information on their exposures when the responders were down there, and detailed information on their physical and mental health as they've grown older. But also as they've grown older, they've developed other health problems that weren't anticipated because people are aging and we're all developing aging-related health problems. And so we've built that into our program at Stony Brook. For the purposes of research, if people are willing to allow their data to be used for research, we have special consent forms for that. But it's a model program. It wasn't done after Chernobyl. It will hope, and it's not being done really after Fukushima, but it seems to me that is something very important to consider. So I said earlier that the international reports on all these events said that the mental health was the biggest public health issue of all. And yet the mental health services have been completely neglected. So Johan is going to talk about that.
Okay, thank you very much. Can everyone hear me?
Yep.
Zanat, am I okay?
Yes, you're fine, thank you.
Okay. So it was also one of the questions from one of the people on the panel. So why, if the major public health threat was the mental health, why do we know so little about interventions? And actually, if you try to find anything on the internet literature about mental health interventions that were implemented in Chernobyl, there's actually nothing to be found. I know that there have been a couple of programs early on. One of them was the Belarusian Dutch humanitarian aid program, of which was a sort of a consequence of the study that I did, where we found that showed so much mental health and also perceived physical health problems without an underlying physical illness. So we decided that it was important to start something in the Gomel region where we were doing this humanitarian aid program. And just so to remind you, the Gomel region lies immediately to the north of Chernobyl in Belarus. And it was one of the areas that received most of the fallout of any of the other parts of Belarus or former Soviet Union. So that was really a very affected area, and people were very concerned about their health, and especially about the health of their children. And they were very eager to learn what could be done about this. And we wanted, of course, something to ameliorate their concerns, but we found that it was very hard to tell the people that even though they were affected by the contamination from the power plant, that they were actually in reasonable health and not in significant health problems as a result of the radiation, but that there were a lot of things that they could do to improve their health, actually. And some of them were directly related to radiation exposure. For example, people love to go out into the forest and collect mushrooms and berries, which was in some areas which were heavily contaminated, probably not such a good idea. But I think more importantly, and fortunately the people in the public health sector in Gomel understood this, there are many competing health risks which they could do something about. So we decided to include radiation-related health program and mental health program together with general health promotion activities. So one of these activities was that there was one week a year called Health Week, where people were encouraged to improve their lifestyles, to start a stop smoking program, to mitigate alcohol consumption. These were all things that they had an agency to be able to do something about it. I'm not aware of any similar projects that were undertaken, and I also do not know whether they are still doing this annually, but I suppose they are, because this was already in an existing tradition. I also was I'm also aware of the UNESCO project, which was done in all the three affected states, which was, I thought they were a very nice also way to more generalize the recovery, not only focusing on radiation-related risks, but to promote healthy community. And I think this is more in line with what Professor Amatov told us about the UNDP program. And I'm not sure whether any other of such programs have been conducted. Probably they have been, but they were not published, as far as I know. So I think one of the things that I really think is something to regret is that we, first of all, maybe undertook too little to really address the mental health problems in the broader sense. So in combination with the physical and also with the socio-economic problems, but also that what programs there were, they were not really formally evaluated and they were also not published. So that is, I think, a lost opportunity, which means that to date, we cannot really learn a lot from Chernobyl in terms of interventions. And well, as it was mentioned also in the introductory document that we received for this seminar, we are now in the middle of the COVID crisis, and perhaps there are some similarities, probably there are some similarities, and we could have learned from how to deal with that in terms of intervention for the mental health and social impacts. I think in Japan, we see that that has been done significantly better. I'm aware that there are a number of programs, especially involving public health nurses in Japan, who have helped people with their concerns with the radiation exposure, but also with the consequences of the evacuation and of the sometimes even more significant losses that they suffered from the tsunami and the earthquake, which had a huge death toll and an enormous impact on the population residing in that area. But again, here, very little has been published, and as far as I know, no really good evaluations, studies have been published about Japan either. And that's really, I think it's really a missed opportunity. So what are the, just to conclude, and I think this is something that we might spend some time in discussing with the people who are on the panel. What is the relevance of all this for the current crisis that we're in? The first thing that would come to my mind is that I would expect that the threat of the COVID epidemic that's currently going on might be pushing people's concerns about the long-term effects of the Chernobyl a little bit to the background, although I might also imagine that for some people it would actually rekindle them so that they would be more worried about it and to remember all the threats that they have already been exposed to. There are similarities in terms of there's an invisible threat and a chance that you might get ill anytime. Although I think in the case of COVID, this is of course much more tangible in terms of that there are tests available and there's a clear-cut medical condition which can be diagnosed, which was not the case after Chernobyl. So I think there's things to be learned, comparisons to be made, but also large differences. Another striking similarity which comes to mind is the role of contradictory information, which was, of course, in the case of Chernobyl, which was rampant, but is also now again with COVID. There's so many alternative truths out there that for lay people, it's probably sometimes very difficult to make out what is truth and what is not truth. And I think this adds to the anxieties and thereby also contributes to the mental health effects. So I hope that what we can learn is that it's more important that in cases of nuclear accidents or any other major threat, such as, for example, the COVID epidemic, it's very important that the professionals are really communicating clearly and in a consensual way, and not to contribute to the disarray and the disinformation that we see all the time. So I would like to leave it at this, and thank you very much for allowing me to take part in this presentation. And I'm looking forward to what will be said about these topics, which I think are very important in our panel.
Thank you very much, both Evelyn and Johan. So we're running behind the time, unfortunately, because it turned out a little bit longer than planned. But the presentation was extremely interesting, and I very much agree on many points you raised. Although I wouldn't like to say that Fukushima mental health studies is a lost opportunity, because we work closely with Japanese colleagues, and we know that there is a massive research going on at the moment, and there were recently a couple of presentations, actually systematic reviews of these studies, part 1 and part 2, tandem publications, quite interesting. And also for our new publication, which we launched last year, I will be talking about it at the end of the webinar. We also collaborated with Japanese colleagues quite closely on that. So,
no, I didn't, I'm aware of those reviews, but I meant about the intervention studies. And the review actually mentions that there is a lack of intervention studies done and publications.
Studies of intervention, yes. That
yeah. So that is, so we know a lot. We know a lot about mental health. Fukushima more so, but even in the case of Chernobyl, we have at least a few good studies, but we have absolutely nothing or hardly anything in terms of interventions, and they would be really needed.
I see. I think it was important to clarify, because it's true that we really do not have at the moment the studies which would compare one intervention versus another, or evaluate the efficacy and the long-term impact probably, or cost efficiency. This type of studies, there is a research gap in that area indeed. So after this, I would like to really quickly, swiftly move to the next presentation, which is going to be done by Patrick mesch&moser. Patrick is from Austria, from Vienna. He's the founder of the mesch&moser situation management, the consultancy firm, excuse me. This company advises to governments, companies, and other international, other organizations on questions of risk and crisis communication, decision-making, and exercises. I met Patrick when he was the spokesperson for crisis communication at the International Atomic Energy Agency, and I was really impressed by his work. Prior to that, he was also a spokesperson for one of the world's largest airlines, and prior to that, also for one of the largest pharmaceutical companies. So despite his youthful looks, he is actually quite seasoned risk communicator, and he holds master's degree in international relations and history. Patrick, the floor is yours.
Yeah, thank you very much, Jeanette. I hope you can hear me well.
Yes.
Perfect. Yeah, thank you very much. And meanwhile, I got also the equipment working. So thank you very much for inviting me to this important seminar. And I'm really humbled to be one of the speakers here. Great presentations and very, very valuable insights that we've heard already. Jeanette asked me to talk a little bit off topic, I would say. Yes, the initial thought was to look at Chernobyl and also, of course, think about crisis communication, risk communication, also the things that we just heard, how important also the psychological effects are that are, of course, connected to effective communication. But at the moment, we have a different health emergency there, a different health crisis, and you all know the COVID-19 crisis. You heard about it for more than a year now. And so I want to give you a short look or discuss with you some things that we might be able to learn from COVID, also regarding radiation emergencies, but the main focus will be on learnings from COVID-19. But coming back to why we are here together today, the 35 years of the Chernobyl accident. This is me at the 29th of April, 1986, I think, at my favorite place to play a little bit soccer with my dad, who was a trainer. And I really enjoyed it that day. But on the 30th of April, there was a big rain, a big thunderstorm in my home region. And after that, we realized, or the authorities realized, that there have been a lot of radioactive material, especially cesium-137, fell out. And in that region, still today, the contamination is quite high, especially, of course, in deer, in wild boar, in mushrooms, and you know all about this. And all of a sudden, the next day, I was not allowed anymore to play football, and I actually didn't really understand, because I couldn't see something, couldn't smell anything. And lucky me, my dad used to be an engineer. My mom was a very considerate person, and they did not panic. They looked at all the facts and they took good care. We were careful, but we didn't listen to all these conflicting information that was just mentioned before. For example, about taking iodine pills. There were a lot of news articles also in our region that were recommending taking iodine, stable iodine. And there were a lot of rumors, a lot of false information out there. So also back then, 35 years ago, we saw that problem. And we've just talked a little bit about similarities between these two health emergencies. And although there are a big difference, of course, and also when we come to these factors, there are differences. Nevertheless, the risk perception factors are quite the same. We cannot see the threat. We cannot feel the danger. We cannot smell it. And we don't actually know too much about it. The complexity is high, so many authorities involved. It is an international emergency with so many different countries with different approaches to disaster management that add to that complexity. And the public interest, of course, is really high. And we all know that when the public interest is high, the media attention is high. And when the media attention is high, we have a lot of information out there that is very good, but also a lot of information that is not quite useful to estimate your own risk. At the end, it comes back to uncertainty. This is what I felt when I was a little boy back in 1986 during the Chernobyl crisis. And this is what most of the people feel today. They're uncertain. They don't know how lethal it really is, how the mortality rate really is. It's different from country to country. There are a lot of conditional probabilities that are hard to grasp. So uncertainty is actually the main factor that we need to tackle to make sure that the people get an insight of their own risk exposure, at least an idea of it. And how do we do that? We do that by taking care of all these factors here, by taking care of all these principles of effective information, effective crisis communication. You all know about this. Be open, be proactive, be accurate, be understandable. Of course, we all know it. But this gets harder and harder because the conditions that we live in, the media landscape has changed. And if we look at COVID-19, this is really a mirror of the changed media landscape, of the changed way we exchange communication, and how we exposed to a tremendous amount of different information of different quality. And this is also why COVID-19 is a pandemic plus an infodemic. And this was an expression coined by the WHO, very, very good expression, because it's exactly what it is. Not only the virus spreads like like virally, literally from person to person, also information and often, unfortunately, mis and disinformation spreads like a virus. And so here we have the definition by the WHO, what they think or what they believe is the best description of an infodemic. The main core point is here that we are overwhelmed by the tremendous amount of information, but also, and that has been said before by speakers previously, conflicting information, information that is changing, expert opinions that are changing over time. And I think we all have these kind of changing opinions in our heads when we think about the COVID crisis. So yes, COVID-19 is a pandemic and an infodemic, but we need to also to be aware this will not only be COVID. Every health emergency from now on with this scope, with this international importance will become an infodemic as well, and we need to be prepared for that. Why is this so important, and why is such an infodemic dangerous? And this is when we talk about Nobel laureate Kahneman's system about fast and slow thinking about system 1 and system 2. This is very interesting because when we look at the fast thinking system, this is basically in our backbone. This is basically that comes straight as a reflex back from ancient times when we have to defend ourselves against threats. This is something that happens automatically. This is something that happens emotionally also, and this is something that happens usually unconsciously. So, for example, if you're driving your car, you've learned a lot of things. You do it basically unconsciously. Sometimes you kind of catch yourself not knowing was the traffic light green or red because you were just driving automatically. But as soon as I go to system 2 and give you a simple calculation to calculate, you realize that your thinking, your reactions will slow down because all of a sudden system 2 sets in, which is an effortful system, which is a system that involves calculating, estimating risk, thinking, taking different information into account, taking conflicting information into account, and it happens consciously. So it takes a lot of time and energy to do that. And so when we think about this, then it's no surprise that when we have too much information, too many details, too much fact, also conflicting information, that there is an overload. And there will be the TMI effect. And believe it or not, even we are in this audience, TMI is not 3 Mile Island in that case, it's the too much information effect. And if we look at this chart, we have uncertainty and the complexity of information, a complexity of information, volume of information, grade of detail, whatever. And we see that in the beginning, often when there is a health emergency, when we do not know too much about it, there's a higher level of uncertainty. And because the people don't get the information they need. And this is our first fake news zone. The longer this situation takes with not enough information, there is a big chance for people to kind of invade the brains of the people with misinformation and disinformation. But then you can see with growing volume and grade of detail of information, the uncertainty is going down because now the people feel, okay, now I know a little bit, I have a rough idea what's going on. They can process it. They switch from system 1, the fast thinking, to the slow thinking system, and it's not overloaded. They can calculate, they can look at their own situation. But if we then go too far, press too much information in there, or information is faulty, is wrong, is contradictory, or is too complex, then we come to the second fake news zone, because then the level of uncertainty rises again, because the uncertainty level in the population is an inverted bell curve when it comes to the relation to volume and grade of detail. And there's sheer overload by volume when we look at the COVID crisis. You can see this is just from in the week 18th to 24th of June 2020, there were 26 million mentions on on social media, and sorry, this is a mistake, it should read 2.7 million mentions on traditional media like TV, the news, newspapers, and so on. So the whole channels, everywhere where you could get information from, was full with this information. If you check out today, maybe just go to your computer, there's roughly more than 6.5 billion Google hits on COVID-19 right now. So there is a lot of information, an abundance of information when it comes to COVID-19. And of course, we had conflicting information. We all know about the discussion about should we wear masks, yes or no. And of course, the people might understand that there's a change in the expert opinion because also new facts came in, new research came in. But then we need to explain that, as has been said before. We need to explain why we change our information, because otherwise the people will think they don't know what they're doing and they don't know what they're saying. Yesterday I should avoid masks. Today I need to wear FFP2 mask. What's going on now? And of course, also fake news are making the lives of the people really hard. Some people, for example, that the Pope has contradicted COVID-19. They're just clickbait. They just want the people to click on their site, and then they get revenues from advertising agencies. But there are more dangerous fake news out there, deliberate disinformation also. So this is a big problem. So if we look at this open, accurate up to factual, as we don't have too much time to discuss everything, and risk communication is such a broad topic, I want to concentrate on these three items: understandable, timely, and active communication that make our communication, or risk communication, effective. And considerations for more understandable communication. If you think about, for example, the discussion if the vaccines that we're using today are causing thrombosis, blood clots. This is a big discussion, at least here in Austria and Germany, but I think all over the world where these vaccines are used. And often you can read there have been 59 cases of thrombosis, or you hear it in TV. What do we make out of this? That sounds, wow, 60 people, maybe 10 of them died. This is a big number. But I don't know about the real risk. It's just a number. Then you can say, well, okay, the risk of thrombosis equals, when you get a vaccination, 0.0014%. Okay, there's a kind of a relative comparison there, but does the ordinary people really can make something out of it? Maybe, maybe not. But if you say 59 in 4.2 million vaccinated people developed a blood clot, I'll also maybe not use thrombosis as a word, you might be able to get a little understanding that the risk is not so big. And if I scale it down a little bit more to things that I can imagine a little bit better, like smaller numbers, around 1 in 100,000 develop a blood clot, that might be a little bit better to compare the risk. And of course, then I can also compare it to people that get blood clots from being infected or sick of COVID-19 itself. And I realized that, well, okay, that's really a lot more than get the blood clot after the vaccination. But words alone might not be able to help here, because we all think in pictures. If I say a pink elephant, all of you now have a pink elephant in your head, and imagine that. So we can also think about maybe, is there a way how we can give this information in a more visual way, in a more optical way. And so one consideration is just trying to make risk a little bit more visible, and trying to use, for example, also these icon boxes that are also, for example, favored by Gigerenzer or Sigmund Fischer, who did a lot of research on risk communication in healthcare environments. Considerations for a more timely communication also. Timely is not really equaling fast. Fast is a part of it, but timely is not only fast, not only be the fastest to communicate. Timely means that you give the right information at the right time without delay. And that's very important. And how do I know when is the right time for which information? Well, basically by monitoring what the people are asking you or what the people are saying. This is very interesting research from Finland, the Finnish authority for healthcare there. They established a monitoring system where they monitor all the questions that they receive, also monitor social media about what are the people talking about COVID-19, and then they do a behavioral analysis with behavioral experts. They do a report on what they found, a weekly report, and then they discuss what does that mean for our communication. Where do we need to adjust our communication to make sure that people understand what we want to tell them? And with this, you can adapt your messages and specifically counter rumors and misinformation that is out there. That's very interesting, and the study is mentioned here. Have a look if you want to. And what are the parameters that are analyzed in this monitoring? It's the beliefs of catastrophic potential of COVID-19, its beliefs of controllability, I'm sorry, and also, of course, the trust in authorities is, of course, also important, because without trust and the credibility of the authorities, all the messages are not as effective as they could be. And also, when we think about be data-driven, that was the headline above all, is have a look at this, this little chart. This is very interesting as well, because it shows the blue light shows how often the people Googled for COVID-19 in the internet, and the red line shows actual cases of COVID-19, so reported infections. And you can really see that there the amount of searches on Google is a good predictor for a kind of increase of infections to come. Why is that? Well, the people that did that study, they say, well, we see that the people, as soon as they have people that feel sick in their environment, they start to Google for COVID-19 symptom, and maybe they only go to a test a week later. And so you have the delay between Googling for it and the real report of the infection. So that's a very interesting thing as well. Consideration 3, also plan in phases when we talk about timely communication. And radiation emergency is usually a very eruptive emergency. So when we look at Chernobyl, there was the explosion. There we had a time of the urgent emergency response, and then it went down a little bit, but it will never, of course, reach the previous level of intensity, because we have to deal with this emergency for the next decades as well. The pandemic is an escalating pandemic. At the beginning, it doesn't seem to be so serious. You hear about a first outbreak, then a second outbreak, a third outbreak, but all of a sudden we find ourselves in a lockdown, because all of a sudden our incidence is whatever, 100, 200, 300 in the country we live. And we need to understand that these phases are different from a health emergency to health emergency. In an eruptive health emergency, for example, at the beginning, don't bother the people too much with detail, not too much with projections. You need to tell them what do they have to do now to be safe, to tell them about protective measures, and then you detail, then you go into the communities, then you talk with the business people that are affected, you talk about the people that have been evacuated, about the perspectives if they can go back, and so on. So that is very important, and you can plan for this, because we know how these emergencies develop. And last but not least, considerations for more active communication. This is just a chart that shows you, it's not related to Chernobyl, because back then we didn't have any social media. So it was actually very easy. If you want to convey a message, we just went on TV or on the radio. And now we see that the amount of social media has skyrocketed, and we see that more than 50% of the world population, they are at least in one, engaged on one social media channel, at least one. So I often hear, especially also from scientists, I don't want to be involved in social media because every fact, they just get twitched there, and there are lies. I don't want to do that. Okay, I can understand. It's really a problem. It's a challenge. But we need to distribute our information where the people are, and the people are right now not so much in front of the radio set anymore, but they are on social media. And for example, the youngsters between 14 and 24, they are even almost not anymore on Twitter. They're hardly on Facebook anymore. They're on Instagram and on TikTok. And the question is, do we reach them there with our well analyzed information, with our information that hopefully has been well coordinated so we don't contradict ourselves? And actually the WHO is one of the front runners when it comes to that. And you can see here their channel on Facebook, on Instagram, on TikTok, and on Twitter. So basically they're everywhere, and they can reuse all their graphics. They can reuse the tools that they use to make the risks visible, that we talked just a couple of minutes before. On all their channels, they can reach out. And even though maybe some people might not read it, some people might not, or not everyone gets the information, many people do. They kind of forward it, they like it, they share it. And so with this is one of the best tools to counter false information and to be effective and active in information and communication, because this is the most important part when it comes to dealing with health emergencies in the age of infodemics. And with that, I thank you very much for listening to me, and I go back to Shana.
Thank you so much, Patrick. A very interesting talk. I always really enjoy listening to your presentations. So we only have 15 minutes remaining, and there is still one more presentation on the program, which I am suggesting to, this is my talk presenting the new WHO mental health framework. I think I will just shorten it and just bring you directly to the key points of my talk, if I manage to share it. It was prepared jointly with my colleagues from the WHO Mental Health Department, and specifically Dr. Fahmi Hanna, who is our in-house expert on mental health in emergencies. So there was already many things said about the importance of the mental health impact, and the studies which were done, and the dimensions of the impact. What I wanted to say that, in fact, WHO has already addressed the issue of mental health in emergencies, in other types of emergencies. There is an interagency standing reference group on mental health and psychological support in emergency settings, and WHO is chairing this group, this reference group. So with IASC partners, WHO has published a range of practical tools and guidelines to meet the mental health needs of people affected by emergencies, conflicts, natural disasters, etc. And these are extensively used by the largest international humanitarian organizations active in mental health. What happens in the sector of nuclear emergencies and radiological emergencies, there is also a very well-developed system of international safety standards, safety guides, recommendations on how to prepare and respond to radiological nuclear emergencies. But this system, despite emphasizing that there should be arrangements on addressing psychosocial impact of this type of emergencies, none of these guidelines documents actually offer practical guidance on how actually to do this, how to tackle psychosocial impact. From another hand, we have this plethora of documents developed by the Interagency Standing Committee in the disaster response sector. So the actually dilemma is how to bring these two, let's say, silos together, which so far have not been co-integrated. And I think there is this really a good opportunity to bring these two closer together. So what WHO has done ever since Fukushima accident, we've been advocating and pushing for this integration of two sectors closer, bringing it to the attention of the international community and donors community in many, many fora, conferences, workshops, etc., conducted also webinars. Eventually, we joined forces with the Nuclear Energy Agency, which is part of OECD, based in Paris. there is a working group addressing nuclear emergency matters, WPNM, and they put it on their work plan to develop, to address this issue of psychosocial impact. But obviously, Nuclear Energy Agency needs additional expertise related to public health, and that's where WHO came in. We joined this project, and as a part of this project, during its first part, we developed the policy framework document based on all the existing guidelines for mental health and emergencies by adopting them to the nuclear accident scenario. And as a phase 2, after developing the framework, which is I'm presenting here now, the second part of the project is now ongoing. We are developing derivative products, practical tools based on the mental health and psychosocial support framework. So we launched the framework in November last year. This is the link to see the launch of the document. I also shared that link in the chat of this webinar. Some screenshot of presenters. So we had international experts from Japan, from Germany, from UK. This is an NEA colleague and our colleague from Mental Health Department and WHO. So I skip the structure, just quickly want to point out that these 5C components, which are very important cross-cutting issues throughout the entire, applicable throughout the whole emergency cycle, which is coordination, communication, capacity building, community engagement, and sticking to core ethical principles. These are elaborated in the document. And for the sake of time, I will not read through, but I also shared the link to the document in the chat of the webinar. Please feel free to download it. It's for free in PDF and to get more familiar with it. There is this very classic pyramid of psychosocial interventions, and notably at the very basis of the pyramid, there are very simple things which have lowest cost in terms of cost efficiency and interventions cost, which are applicable to any type of the group in the society. It's even families or schools or local communities. These are basic networks which all of us are using when we turn in terms of hardship to our friends, to neighbors and family. Then, so it's so-called informal community care. Then there are some specific, more targeted and more formal structures which are being put in place. And then goes even further specialized and smaller group of people being addressed, eventually those people who need clinical psychiatric care. And obviously this one will be at the lowest proportion of population, but the highest cost at this level of intervention. So the key messages of the framework are that what already was said, that radiation emergencies, they have unique mental health impact type of factors which affect the mental health. And all the psychosocial consequences, they may outweigh the direct health impact of radiation itself. Sorry, go back, not finished yet. Public health approach with an emphasis on MHPSS intervention is essential for planning and responding effectively to radiation emergencies, and it must include interdisciplinary capacity building to ensure that MHPSS is integrated within existing arrangements for each sector involved into the response. And in this sense, cross-sector coordination is paramount for efficient implementation of MHPSS. And as I said, we really need practical tools to address this type of impact of nuclear emergencies at the planning stage. And we are now working on this specifically with NEA to develop checklists, decision-making tools, some infographics, etc., and training materials as well. And as what was already mentioned, that research is absolutely important, and we need to further understand mental health vulnerability to radiation emergencies to evaluate mental health interventions, efficiency and impact of these interventions in order to strengthen the evidence base for appropriate and efficient mental health actions. This is the end of my presentation. I stop sharing, and for the remaining few minutes, I would like to address the questions. It appears that we have few questions, not so many, but if you allow me, I would go ahead and read the question. Our very active participant of all WHO webinars, Dr. Prakash Hanna from Singapore, he's a molecular biologist. He's asking, for COVID-19, it appears that science may not be risk communication that has not worked efficiently. Messages on social media are not translated into different languages in different countries, for example. In science, communicators, journalists would have tried to communicate better on preventive measures. This would have helped a bit in changing people's behaviors and awareness. I am not generalizing. I felt more should have been done by science communicators and journalists in this era of infodemics. Well, this is rather than question, I think it is a more general comment. I don't know if Patrick, you would like to comment on that?
Yeah, thank you. Yes, I think it is. It's correct. There are a lot of gaps and a lot of things to improve. But on the other hand side, it is also, as I just tried to show, it is a huge challenge, and the challenge is growing every day. I think that what has been mentioned from Johan also already is it's very important that the experts also understand that it's crucial that they also make their discussions a little bit more transparent, and so the people understand also how maybe a change of decision takes place, and not so much just only single, maybe very famous scientists that show up in the newscast every day. Maybe this is also a chance to improve the risk communication.
Thank you. Another question is on let's say, in terms of lessons learned, if there was a chance of an epidemic happening during Chernobyl, could it be a difference regarding Chernobyl disaster mitigation? I guess the question is about the response. If it happened nowadays, Chernobyl accident, what would be handled differently in terms of managing infodemics? I think we can maybe make a parallel with the Fukushima disaster, which is the response is happening exactly in the area of social media presence, on people being connected and overwhelmed by information. So this would be an example how things would have been handled differently as compared to Chernobyl accident, which happened in the times of Soviet Union, when information sharing was not really a priority at the time, as we know that the Soviet Union government actually initially did not share the information during first days with the global international community. So that was a big difference. But I would like also to ask Professor Bazika, in terms of the recovery, you've been there for the 3 decades of recovery process. What do you think are the main lessons we could take for planning for the next nuclear disaster? If it happens, hopefully not very soon, but it may eventually happen, let's say in 20 and 30 years. So what should we really take care of in the planning stage for the recovery, long-term planning for recovery process?
I think that speaking about recovery, we can say that several items could be averted. For example, if we speak about the settlement and resettlement and relocation, we have studied there are mental health and stress disorders related to relocation in people. And this relocation was politically influenced, I can say. It was not adopted by science. Mm-hmm. This is the first. The second, you see in Fukushima, there was much better attention to the cleanup workers, because in Chernobyl, 600,000 of cleanup workers were implemented for liquidation of consequences of Chernobyl. Not all of them were in need. There was a lot of people who were excess people So there was the defect of planning. And after that, we have this big amount of people who have radiation doses and we have elevated risks. And maybe one of the most important is the iodine prophylaxis, which was not performed as needed. Mm-hmm. You see, Poland is quite near Ukraine, and in Poland, the iodine prophylaxis was performed, and they have none of the cancer of thyroid. And we have epidemic of thyroid cancer that is not finished till now. And those who were adults and those who were children at the moment of accident.
Yes. You contributed to the NRCRM's white paper published in 2017, the update on thyroid cancer, which mentioned that as of, I believe it is up to 2005, there were 20,000 thyroid cancers diagnosed. And the report also states that there are some 0.25 fraction is attributable to radiation risk. Does this imply that only 1/4 of the 20,000 is actually due to radiation exposure, and the rest of it due to the people actually growing to the spontaneous age of when spontaneously thyroid cancer is developed, and also to the improved diagnosis because people are aware of their risk and they undertake the examination earlier?
This differs with the age at which thyroid cancer was detected, because in those who are early children, the risks are very high. In general, speaking about Ukraine, the number of thyroid cancer in males and females in the national, when we speak about the national parameters, increased twice. Of course, some part of this increase is related to a screening effect by the use of ultrasound, like it was in Fukushima also, when the very sophisticated ultrasound was used and everything was found that was not found before. But the situation is that number of cancer increases, and if of course we take the population in total, then the attributive fraction will be 25%.
Mm-hmm. Okay, thank you for your answer. Also, I would like to ask the same question about planning for in advance for a long-term recovery process in terms of mitigation of psychosocial impact and mental health impact. What do you think should be done? Very briefly, what are the main points? If you could comment on that, Evelyn and Johan. You need to unmute yourself, Johan. Could you unmute yourself? You are muted.
Okay.
Yeah.
Thank you. Well, the first thing is, of course, to prevent nuclear accidents happening. And that's, of course, a big debate these days from whether we need nuclear energy to combat the climate crisis. So it's a very topical subject. And the other thing was already mentioned, that you should, people who are living in areas surrounding a nuclear plant, they should be informed before there's an action, but they should know that they're there, and maybe there's arguments pro and con distributing stable iodine in advance. The risk being that people might misuse it, and that if you a large percent of the population takes iodine without a need, then you get all kinds of side effects such as allergies, etc. So it's not an easy question, but these are the sort of thing that you can do. And then from the beginning, I think communicate more transparently and more along lines that Patrick described. But I think that's a reflex, you know, if these accidents, to my knowledge, not a single nuclear accident that was immediately followed by transparent and honest communication from the side of the experts. So this is really apparently very difficult.
Indeed, for different reasons, yes.
Yes.
In Fukushima, we know that there was disrupted communication lines due to the tsunami and earthquake. So there was probably different reasons for lack of communication at the early stage. But I would also comment on that, that's to say that whatever communication comes out, it should be coordinated between all respondents, the responders, responding agencies. We should not give confusing messages and create anxiety more than necessary in the affected people.
I could just add, it should not only be coordinated, it should be truthful. I mean, there is a tendency after all of it, it's not just nuclear accidents, you know, other kinds of toxic events. We had one at the Brookhaven National Lab here on Long Island. And the immediate response was to deny that there was any problem and basically to lie to the community. The community knew they were being lied to. And so it leads to a cascade of difficulties in communication. So I think being truthful is important. And I think the other thing Johan said that really is just incredibly important after nuclear accidents is to not use jargon. You know, these people are talking to each other. They're not talking to the community in ways that are understandable to the community. And this just creates, it heightens people's anxiety. They don't know what you're talking about. They don't know what these terms for different aspects of radiation exposure mean. Why would they know that? But there are ways. We have a program at Stony Brook that was started by a very famous actor named Alan Alda, who loved science. And the program is in the journalism school and it's on communicating science. And they not only train journalists to know how to ask questions and how to write their stories, but they also train scientists and how to talk about their very esoteric results in plain language that anybody could understand. And the bottom line from my point of view is if you can't explain your science in ordinary English, then maybe you don't really understand your own work the way you think you understand it. So just wanted to add that.
It's very important, the capacity building for communicators and training for people who will be dealing with management of psychosocial impact is extremely important. Well, Mustafa, would you like also to say some closing words? Conclusion?
Thank you very much, Anat. Coming back to the importance of partnerships and in particular, cross-sectoral partnerships, and also reflecting on the Patrick's excellent presentation, I would like to stress from my side that the issue of trust, which was raised, is actually critical. And channeling, in case of risk communications, channeling the information, actually not reaching only timely, but channeling the information through the right channels is extremely important. And let me just bring you a small example from the one project which I've been mentioning in my presentation, the one called Homeowners of Ukraine for Sustainable Solutions. Within this project, we have, even prior to the crisis, we have established strong partnerships with so-called homeowners associations of multi-apartment buildings. So we were dealing with co-owners of multi-apartment buildings across Ukraine. We have established a broad network which incorporated about 3,500 of such associations across Ukraine. And in the COVID times, we used those channels to spread the message immediately. And we used the information which was provided by WHO, which was verified, you know, it was not based on any kind of misleading information. And we channeled it through these homeowner associations. thus, which allowed us to reach quite a broad audience. We covered more than 2 million people in very short time. But more importantly, that it was channeled through the people who are most trusted at the local level, through building managers, those who are, you know, literally next door to them. So, and this is an example how it can be used, how these networks established, because in our development projects and programs, we always establish networks. And you never know how you can use the power of these networks. And in particular, in this particular case, this is an example how these channels of potential channels of information can be used when times come. So this is my message, that first of all, the information should come timely from right channels, and we can use our well-established partnership networks to spread the message quickly and through the proper channels. Thank you.
Indeed, this type of dialogues and the partnership should be established well before emergencies. It's too late to start to do it in emergency. Obviously, at the stage of preparedness, at the stage of planning, it's extremely important to map the community, to have these type of structures with whom you should be able to work if something like an accident or an emergency happens. Well, we are beyond the time of the webinar, but there are a couple of very interesting questions, and at least one of them I would really like to ask Professor Bazika to comment on, because it relates to his very recent publication. It's published by a large group of scientists led by the National Cancer Institute in the United States. And the paper is in Science magazine about the genetic mutations in children of the exposed people of Chernobyl. So the question is, for you, was it a surprise to find the lack of transgenerational effects from the Chernobyl accident? The paper was actually picked up by BBC, and there is a big, loud title saying that children of Chernobyl do not have genetic mutation, which is good news. So could you comment on that, Professor Bazika? Very briefly, please.
Yes, I will try. For several years, we have performed a study of fathers, mothers, and children to find some effects that are related with the ionizing radiation. What we have found? We have found lack of de novo mutations transmitted from mothers and from families to children, to a child. So there are several factors that could influence the transmission of mutations. First of all, preparation, because we have taken to our study those children who are adults now, and there is a period from 18 to 20 years and more between the fact of conception and fact of study. So this is a limitation of our study. The other limitation is that errors in the human organism are somehow repaired. For example, Dr. Bychkovskaya from St. Petersburg have shown in the flies genetic effects in 10 generations of flies. Some other studies also show, but in humans, nobody was lucky to find and to show such changes.
Lucky for humans.
So we are lucky. We are lucky having this luck of de novo mutation.
Because the regeneration system is much more sophisticated than in flies.
Yes, yes.
Preparation system.
And
so,
of course, we have found not significant changes, but this work has to be prolonged because we have studied only half of our material and this data should be analyzed in future.
So research continues. Okay, so thank you very much for commenting on that question. I would like once again to thank all of the distinguished speakers who provided their valuable contributions to this discussion, and also all 200 participants, 200 plus, who joined the webinar and spent the time listening to us and asking interesting questions. As I said, once again, the webinar has been recorded, and we will place the link to the recording to the website advertising the webinar. So those who couldn't watch it will be able to watch it afterwards. Well, let's hope that we will not have another nuclear accident in any near future, not for us, not for our children, not for our grandchildren. I wish you all to stay safe, wear your masks in public places, wash your hands, get vaccinated as soon as you can, and stay healthy. Thank you very much, everybody. Goodbye.
Goodbye.
Thank you very much.
Well, thank you.